Welcome everyone, this is Yasser from Learn Dental Series. Today we will continue to our discussion about the composite resin restoration. First of all, I would like to declare that I haven't any conflict of interest with any of the discussed products and techniques. Also, I don't receive fees, compensation, or royalties from the sales of any of the products shown or discussed. Also, I would like to remind you that this presentation is copyright protected and no part of it could be transmitted or edited by any means, either electronic or mechanical, without written permission of me. Today we will continue our material review in terms of history and development, types of aesthetic restoration, chemistry of composite, and today we will discuss the types and the classification of composite resin. The types and the classification of composite resin is based on filler size and distribution, types of filler loading, viscosity and handling properties, mechanism of polymerization, and finally presentation. According to filler size and distribution, Bayan and Heyman classified composite, as we mentioned in the last lecture, according to filler size into megafill, which is no longer used now. It's known as inserts, ranged from 0.5 to 2 millimeters in size. Then came macrofill, 10 up to 100 microns, and also not used anymore. Then comes medifill from 1 to 10 micron, minifill from 0.1 up to 1 micron, and microfill from 0.01 up to 0.1 micron, which is recommended for non-stress bearing areas, because it has inferior mechanical properties, but it has a higher surface polishability, and aesthetic also translucency is considered as a positive criteria of microfill composite. It has a very low modulus of elasticity, that's why it is still indicated and the material of choice for restoring class 5 cavities, as it could flex with the same flexion of the tooth when the patient having any parafunctional habits such as bruxism. Then comes the nanofill composite, ranged filler size from 0.005 up to 0.01 micron, which is a non-silicate based composition which is below the wavelengths of visible light. That's why it is a highly translucent material with good aesthetic and at the same time having superior mechanical properties. And the group of hybrids, which is mixing of or adding two types of filler size to get blended properties or amended properties, to combine high strength or superior mechanical properties with superior aesthetic properties. Like that, the first hybrid was only termed hybrid, macro and microfill, midi-hybrid, midi-fill and microfill, mini-hybrid, which is mini and micro, and nano-hybrid, mini-fill with nanofill. According to the type of filler loading, we have either homogeneous composite or heterogeneous composite. Homogeneous composite or homogeneously fill, which is the original prototype composed of organic resin matrix and usual inorganic filler. But the heterogeneous fill composite, part of its composite filler is a pre-polymerized composite. Then you divide the amount of composite into two parts. One of them is pre-polymerized, crushed and grinded to be used as a filler in the other amount of composite. And this is considered as a maneuver from the manufacturer to reduce the polymerization shrinkage inside the cavity preparation or the clinical volumetric changes inside the cavity, as part of your filler is a pre-polymerized composite. Then comes the classification according to viscosity and handling properties. According to viscosity and handling properties, it is related to the amount of filler. Regular composite resin with percentage of filler loading ranged from 65 up to 80% by weight according to the size of the filler particles and the amount of the filler. It may be midi, mini, micro, nanofill, or any of the hybrids. Viscosity of the composite of this composite differs according to the filler size. That's why the diluent added amount differed in percentage to control the handling and the viscosity from one filler type to the other filler type. And this is a commonly used composite either for anterior or posterior whatever the cavity size it could be used. Then comes another innovation, which is the backable composite, which is introduced with a larger filler particles, which is fibers or porous filler particles, maybe irregular filler, okay, and viscosity modified. That is to have handling properties such as that of amalgam, to be easily condensed inside the cavity, okay, and to lack the thickness of composite to the instrument, and this aims to reproduce a tight proximal contact or reformulate a proper contour and the tight proximal contact integrity using composite resin material. But as we mentioned in the previous lecture, it failed to achieve these goals, okay, because it has too many problems, especially for adaptation, okay. It shows a very low wetting that inferiorly affect its adaptation to cavity walls and margin. That's why they developed another type of viscosity of composite, which was the flowable one, with the benefit of ease of adaptation of the preparation as it flows and coats the floor, okay, to just improve the adaptation of the first increment of backable one. Now the system of backable and flowable of two consistency system, okay, it is not common nowadays. Backable is rare, okay, but flowable is still used up till now, either as a liner under composite or to block out undercuts, okay. But you should know that it has an increased polymerization shrinkage, and it has more fatigue and high flexion due to its low modulus of elasticity, and some clinicians consider this as an advantage to use it in class 5, especially in patients with abnormal occlusal habits or parafunctional habits. It has a low strength with high discoloration rate. This photograph showing you the difference in consistency and at the same time the difference of wetting and the flow of the three types of materials. The regular one in the middle, to the left backable one, and to the right is flowable one. And as it is flowable, it is applied using a special needle, okay. It could not be cut in slices and backed inside the cavity. This is the use of three of them. Regular one is the most commonly used in general, okay. Backable is now rarely to be used or not recommended. Flowable could be used, as I mentioned, as a liner under composite or to block out undercuts for indirect two-scalared restoration, and for class 5, especially if the patient have parafunctional habits. According to the mechanism of polymerization, we already discussed it before. Either we have chemically activated or light activated material. Chemically activated by tertiary amine, which break down the benzoyl peroxide activator. That's why it comes in two base system, one of them having the activator and the other having the initiator, okay. And you mix equal amount of each parts. That's why when you are mixing it, there will be an entrapped air which impaired its aesthetic quality of the material, okay. Light activated one is activated by ultraviolet, which is not anymore used because it's harmful effect on the eye of the operator, okay, and also the patient eyes, okay. Now we use the visible light cured in a range of 460 or 480 nanometers, produced by either quartz tungsten halogen devices or light emitting diode device, which is the most commonly used one, and with limited problems, with no heat generation, as we mentioned in the previous lecture, okay. Initiator is camphoquinone, and we need a light absorber to fasten the decomposition of camphoquinone in a form of benzoyl methyl ether for ultraviolet, and now we used alpha diketones, which are aliphatic amines for visible light cure. It comes as a one-based system, readily available. Just you cut a piece and back it inside a cavity. That's why the material is readily available without mixing. When you compare them again in terms of working time, chemically activated having a limited working time because the setting reaction starts once the two based increments touching each other, then the activator meets the initiator and start to break it down, starting the reaction. Okay, that's why your setting reaction starts upon mixing and extended until all the activator consumed all the initiator, released all the free radicals, and produced maximum cross-linking. That's why we considered it as having a homogeneous polymerization reaction with maximum rate of conversion. Okay, but the color and shade is a poor quality because already you have entrapped air that negatively affects its aesthetic quality and negatively affects its physical properties and mechanical properties. And its technique sensitivity is limited only for working time, and moisture and saliva is already a factor for technique sensitivity for all types of restorations, especially composite. Okay, while the light activated system is having a flexible working time because it will not start its setting reaction unless you emit a light, the required light activation from the device. That's why it is considered as having extended working time and command setting. Okay, but this affects the conversion rate as it is considered as having unhomogeneous or heterogeneous conversion or polymerization, as its polymerization and conversion is affected by the light emission, okay, and time for light emission and the thickness of the material. If the material is thick more than 2 millimeters, then the part more than 2 millimeters or beyond this 2 millimeters will not have enough light activation to break down its camphor-quinone initiator to get the reaction and get the maximum properties. Its color shade is high quality because it is a readily available material, no mixing, okay, but it is sensitive to ambient light. You could not guarantee that when you open and close your light cured composite tube, okay, it is not set or starting any setting because it is not subjected to the light cured device, okay, and not subjected to any emission of light. No, this is not true. It is sensitive to the ambient light, okay. You will start a very slow setting reaction when you let your composite tube uncapped again after you cutting a piece of composite. It will absorb a light wave, okay, within the range of 460 up to 480 from the ambient light of operating room, okay, until it gets enough energy in joules to set the material, and this may affect its expiry date and its shelf life. Take care of this. In addition to moisture and saliva, as we mentioned before, it is a factor in technique sensitivity for all the materials, especially composites and bonding. When you compare them in their shrinkage pattern, okay, as we mentioned before, chemically activated composite in general, composite is have a shrinkage towards the center of initiation or towards the area of maximum initiation. The area of maximum initiation in chemical cured composite is the center. That's why it shrinks towards the center, okay, and this is considered as a positive advantage, okay, and a negative disadvantage at the same time. A positive advantage when you used it as a core for post teeth, okay, it will shrink towards the post, okay, anchored more to the post, okay, and this is a favorable indication. But when you insert it inside a cavity with 4 walls, it will also shrink towards the center, but towards the center it will leave the margins of the restoration, okay, making a gap with remember that also it has a maximum conversion that it will have a maximum volumetric changes, and this will lead to micro leakage and gap formation between the composite and the cavity walls. That's why it is uncommon now, or nearly not used or contraindicated to be used as a restoration for prepared cavity, but it is successfully used as a core for post material. While for light activated material, it shrinks toward the first area of initiation, which is the light direction, okay. it shrink towards the light. Okay, that's why, okay, we could use this for our advantage, just bringing the light from the side, the same side of cavity wall, and your composite will shrink towards the cavity wall, okay, making it an advantage of adaptation for your composite. Okay, for light activated composite material, as we mentioned, it could self-decompose as a result of cumulative effect of ambient light. That's why they added inhibitor to prevent this self-decomposition. And accordingly, your composite material is supplied in a tube of dark opaque thick plastic tube material. Okay, and the composite resin should be recapped immediately after slicing the required increment. Unused composite resin tubes should be stored at refrigerator. And remember that light shade is highly sensitive to light than darker shade. Okay, that requires sometimes you should switch off the dental unit light, especially when using light shades and enamel shades. Okay, when you have unused composite resin tube, okay, that is not used for a long time, you should squeeze a slice of 1 to 1.5 millimeter thick of this composite and discard this slide, okay, if it is not used for a long time, because it may contain, or either it may be self-decomposed, okay, or oxygen inhibited layer. Okay, then the last one is classification according to presentation. As we mentioned before, chemical cured comes in two base systems. This is not our problem, or this is not our discussion now, okay? But our discussion now includes, according to presentation of light activated composite, it comes to you either in a tube or in a cavifill. Cavifill is equivalent to capsules in case of amalgam restoration, okay? The tube is a dark thick plastic tube with definite shade of composite, okay? Cavifills is also a dark opaque thick plastic capsules, okay, that dispensed amount just quite enough to fill small to moderate sized cavity. The advantage of the tube, it is economic, okay, and there is a decreased waste of the material, while the advantage of cavifill, okay, it's a single dose amount, single use, okay, so that you are not in a hurry to remember to recap it or to slice a piece of it, because it will be finished once you use it and remove the cap. It will be finished immediately in a single cavity. Also, it is better infection control, because one of the disadvantages of the tube is the infection control, because you slice a piece, okay, insert it inside a cavity, then your instrument, your plastic instrument, will touch the cavity, will touch the patient tooth, okay. Then again, you use it to remove a part of composite and the tube may be contaminated. That's why it is preferable to have a dispenser, or most of the manufacturer, okay, bring to you with your kit of composite a plastic dispenser, just to cut an amount you needed in to fill your cavity, cover it with a light protective shield, okay, and use it, but never use the same instrument cut composite to insert it inside the cavity, okay. Also, as we mentioned before, the tube, you have an amount about from 2 to 5 grams of composite, okay, could be used many times. That's why remember to recap it. If it is not used, should be refrigerated, and when you use it, should be get out of the refrigerator at least 1 hour before you use it, okay, and slice at least 1 millimeter thick from the composite tube and discard it, because it is either affected by oxygen inhibition, okay, or it is started to set due to decomposition of your initiator. These are the tube and these are the cavifills. This is the applicator of cavifills or gun, okay, to be used. Then comes a very important topic, as we remember, okay, Raphael Bohn invented composite in the dental market in 19 58, okay, and up till now we are into 2023, okay. Still there is a modifications, still there is a manufacturing of different brands, okay, different types of composite. That's why we would like to refine our composite to meet the ideal requirements for restorative material, especially its aesthetic is now uncompetitive, okay, unless you go for ceramic material, okay. That's why nowadays we don't have silicate, we don't have acrylic resin, only we have modified glass ionomer, okay, with a limited use as a final restoration. What are the aim of refinement? Why we need to refine our composite? Okay, we need to refine composite to reduce volumetric shrinkage and increase adaptation. As we mentioned before, please remember, there is no composite with no shrinkage. If you say we have no volumetric shrinkage, then you haven't any polymerization reaction, you didn't convert composite. Okay? If you remember, the higher decomposition of initiator, the higher cross-linking, the higher converting the carbon double bond to single bond, okay, all of these increase the physical and mechanical properties of your final restoration. But at the same time, okay, that means that you have the maximum polymerization shrinkage or volumetric shrinkage of the composite, okay. But we need to reduce the effect of polymerization shrinkage clinically inside the oral cavity, inside the prepared cavity. Polymerization shrinkage, as it increases, it is a good sign that your composite having the maximum conversion, having the maximum cross-linking, because you consumed all the free radicals of the initiator. Okay, that's what is meant by polymerization shrinkage. But only it opens gap between the restoration and the tooth structure at the interface at the cavity wall. This is the adverse effects or the adverse negative effect. Okay, that's why we would like to reduce polymerization shrinkage and increase adaptation in expense of not affecting the conversion rate and cross-tying or cross-linking of the composite material and not affecting its properties. Also, we would like the material to be anti-karyogenic, because if we have a gap, and you will have a gap, we are trying to help the case to counteract any effect of recurrent caries by adding a fluoride releasing property to the material. Okay. Also, we'd like it to be biocompatible, to be highly polishable and color stable, because all composite will undergo wear or abrasion when you are going to finish or polish it. Okay, and we would like to get a highly lustrous surface like that of metallic restoration. Finally, we would like to increase its strength and wear resistance. That's why we have refinement either for the matrix phase or for the filler phase. For the matrix phase, first of all, they added acidic monomer, then they changed the monomer type, okay, into an inorganic one, then they invented what is called controlled shrinkage monomer. Okay, acidic monomer, it is a bisphenol A derivatives, okay, that have been produced both with carboxylic acid and phosphonic acid functional groups without degradable esters. Okay, never mind about this composition, but you are not in need to remember it. Okay, it's detailed too much, okay, for you as undergraduate student, but I need you to understand that addition of this acidic monomer that allow interaction with the dentine layer of your prepared cavity, okay, that may separate an adhesive layer, okay, that eliminate and or improve the effect, the side effects of polymerization shrinkage and improve the performance of the material. Okay, but when they do this, It exhibits a comparable mechanical properties but increased water absorption due to presence of acidic group, okay, and increased hydrophilicity of the material, which by in turn, okay, leads to lowered or affects negatively its final mechanical and physical properties. Example for it, self-adhering flowable composites, okay, and they concentrate or focus on flowable composite because it is the first layer that face or wet the dentine of your cavity preparation, and they would like it to interact with dentine in an adhesive manner, but it is limited use nowadays. Then another trial is inorganic monomers, which is called ORMOSIR. ORMOSIR is the acronym of organic modified ceramics. Okay, what's meant by this terminology? Organic modified ceramics, it explains that you have a ceramic filler, okay, with minimal organic resin or modified resin content. They substitute the organic fraction of resin composite, which is BGMA and urethane dimethacrylate, okay, with another component which possesses an inorganic component of modified silicon dioxide, okay. The main property of this, okay, is to improve the physical properties of the material, okay, but the marginal approximation, okay, is compromised and decreased, and you are still in need to have a flowable composite as a liner under it. That's why it is now limited and nearly it is unavailable in the market. Okay, this is an example of it. Comes lastly in the modification of the matrix is the controlled shrinkage monomer. First of all, when they invented it, they marketing it under the name of no shrink composite. Okay, then low shrink, then controlled shrinkage, which is the best description of your material. Okay, because there are a great objection about the terminology of no shrink. As we mentioned before, no shrink, then your composite is no longer polymerized. Okay, they substituted the type of resin matrix from methacrylate or alpha bisphenol glycidyl methacrylate, which are a linear monomer, okay, into what is called oxirane, which is a ring monomer. What is the difference? Let us discuss it in this diagram. This is the linear monomer, which connected to each other by shifting. These are the monomer molecule, just as you see, it is shifted to each other, leaving this area of volumetric shrinkage. While they mixed silurane with oxirane, okay, which is terminated by a ring molecule. This ring molecule, upon polymerization, number one, it opens, expands, then connect, but the expansion firstly will substitute the coming shrinkage with this total amount of shrinkage. That's why they said controlled shrinkage, okay, or low shrink. Let us see it in these clips. This is the linear monomer, okay, which connected to each other, okay, leaving this space, and this is the total volumetric shrinkage. While the ring monomer, okay, it first opens, okay, when it opens it expands, then connected with minimal or controlled or low shrinkage. Sorry. 3M was the manufacturer who produced it and marketed it, but till now it is limited in use. As you could see, these two bottles, okay, it requires a special type of bonding agent. That's why it is limited. It will not give you the chance to select different types and different techniques of bonding with dentine, which is the most important step when you are performing aesthetic restoration. Okay, that's why it is not commonly used in the market, okay, because it only bonds with a special bond. Also, this bond is based on silurane monomer, okay, or based on ring opening polymerization. Okay, then comes the refinement we made to filler phase, starting with ceromeres, compomeres, smart composite, bulk fill composite, no filler resin infiltration or filtration, smart chromatic technology, or omnichroma. Let's start with the ceromere. Ceromere is an acronym, stands for ceramic optimized polymer. Okay, then we are playing with the filler, changing the type of filler, okay, to have a filler containing barium glass less than 1 micron, okay, spheroidal mixed oxides, yttrium trifluoride, yttrium, okay, trifluoride, and silicon dioxide, okay, about 57% in volume, okay, with dimethacrylate bis GMA and urethane dimethacrylate with regular monomer, okay. Then you're adding a special ceramic filler, okay, that have an durable aesthetic quality and abrasion resistance, and you are not in need to add much more color modifiers in your resin, okay. That's why it provides you with a stable aesthetic, okay, and clinical serviceability from the shade matching point of view, okay, much more higher than other types of composite. And nowadays most of marketed composites, okay, available in the market, having a ceromere filler, okay, available, okay. It is identically to all the physical properties of any other composite, okay, but with improved color reproduction and color stability. Also, as I insisted and repeated on yttrium trifluoride, it is a fluoride releasing material, okay, but not to that extent equivalent or similar to the conventional glass ionomer material, okay. These are a model of it. And comes compomeres. Compomeres are a trial to modify the properties of glass ionomer and to modify the properties of composite resin. You get a material, okay, blended in between composite in its physical and aesthetic properties and the glass ionomer in its biocompatibility and its anti-corrosionity due to fluoride. How they manufacture this material? Simply, it is a composite, okay, with matrix phase and filler phase, but half of the filler content is an aluminosilicate glass with freeze-dried liquid, okay, mixed with your composite. This is a glass ionomer, conventional glass ionomer, composed of aluminosilicate glass. This is the powder of glass ionomer with liquid, okay, polyacid liquid of the glass ionomer, but it is freeze-dried. That's why it is non-reactive. It needs water, okay, to dissolve it, okay, and start the reaction. Then simply you have a composite with powder and liquid of composite stand by for water to get the reaction, okay, and stand by for acidic media to break down the components, okay. That's why it is considered as a composite. That's why it is a polyacid modified composite rather than or more than considered it as a glass ionomer. Why? Because it is a light cured material with unlimited working time. Its first reaction is light cured reaction, okay, that allows you to finish the restoration. In controversy with GIC or glass ionomer cement restoration that start with acid-based reaction, not a resin-based reaction, okay, that needs at least 24 hours to reach the maturation and you could finish it. Then this material starts with resin-based reaction, not acid-based reaction. The details of these reactions will be discussed under the topic of glass ionomer cement, okay, in full details. Then it is not considered as glass ionomer, true glass ionomer. This resin-based reaction means that the material hardened with command setting with unlimited working time, and the material hardened, okay, and this allow you to finish the material immediately. The material surface will not be sensitive to moisture in the first 24 hours like that of conventional glass ionomer. Then Where is the part of fluoride release and what the role of glass ionomer cement incorporated inside, unreacted and incorporated inside the material? When there is a drop of pH due to bad oral hygiene, okay, then your saliva becomes acidic and comes in contact with the material, okay, starting to activate acid-base reaction, and there will be a disintegration of the components, okay, then it will release fluoride. But as I mentioned now, it will undergo degradation and disintegration. That's why you couldn't use the material as a final restoration. It is used as long-term temporary or interim restoration. What is meant by this? I mentioned to you. Okay. Suppose you have a case with multiple carious lesions, all of them are acute and all of them are extensive. Okay. If you started with this case, you are in need, number one, to modify and improve the oral hygiene of the patient. Okay. Educate the patient how to save, okay, his oral hygiene, how to preserve his oral hygiene. Okay. That's why you are modifying the salivary flow from acidic to normal salivary flow. Okay. But then you will start to excavate caries from one tooth to another. But if you calculate the consumed time, you will discover that when you finish all of this program, the case will not be restorable. The case will be referred to endodontist at least for half the number of these teeth. That's why you are in need of such a material. Excavate as much as possible. Okay, stabilize the condition by applying such a material. Okay, until you finish the proposed treatment plan, and this material, okay, in the bad oral hygiene, it will release fluoride, okay, to act as anticarcinogenic until you finish the oral hygiene measures, until you finish the prophylactic measures to the patient, okay, and start to reopen each tooth without endangering the bulb, without the possibility of bulb exposure, just to stabilize the condition. Okay, one of these material is direct. Other brands get the same idea, but instead of releasing fluoride, okay, they adding bioactive amorphous calcium phosphate filler, which is capable to respond to the environmental pH. What is meant by that? When the pH drops due to bad oral hygiene, okay, or due to any periodontal disease, okay, the material will release calcium phosphate in a form of hydroxyl calcium, okay, when the pH drops under than 5.8. To neutralize the acidity and to counteract the effect of decalcification of enamel, okay, it will remineralize your enamel again. The release of these alkaline ions will help in inhibiting bacterial growth, buffering the acids produced by bacteria, and reduce the incidence of recurrent caries by reducing the demineralization effect. That's why it is called intelligent composites or bioactive composite. But also, it undergoes disintegration and biodegradation of the material contents. That's why its physical properties will be affected negatively by time, and the clinical longevity and serviceability of the material is a little bit questioned. Okay, it is also used as interim restoration, exactly the same as that for Composite. Okay, this is an example of the material. Then comes bulk fill composite. What is bulk fill composite and why it is invented and considered as refined composite? When we apply composite into a cavity, or when we decide to restore a tooth with a composite material, okay, we are facing a great challenge of its sensitivity to moisture and its sensitivity to light, to ambient light. That's why the material is technique sensitive. especially when it is an extensive cavity, okay, and you would like to apply much more than 2 to 3 increments, because we are limited by 2 millimeters maximum for each increment just for light cure. Okay, if you could apply a composite in one bulk and carve it immediately, okay, this will solve this great problem related to technique sensitivity and of moisture and ambient light. But now you are facing two challenges. Number one, what about the total amount of volumetric changes as you apply the composite as one bulk? This is number one. Number two, what about the depth of curing? You know that, as we mentioned before, the light could penetrate properly 2 millimeters, okay, of the bulk of composite that will respond positively in a good rate of conversion to this depth of curing. But what about the extra composite more than 2 millimeters? How could you solve this problem? How could you ensure that an efficient curing light could penetrate and reach up to 4 millimeters? Okay, let us see now, okay, how they solved this problem. Number one, bulk fill composites contains a shrinkage stress reliever. It's a special filler of premolar polymer, in addition to your conventional filler. This shrinkage stress reliever having a very low modulus of elasticity, okay, near to 10 gigapascal, when compared to the high modulus of elasticity of glass filler, which is approximately 70 to 71 gigapascal. This filler will act like a microscopic spring that will absorb the stresses generated due to light activation, shrinkage stresses. Okay, that's why your composite will press on this stress reliever, okay, that will relieve all the shrinkage stresses, okay, and at the same time will re-expand again to compensate for part of this shrinkage. This is number one. Number two, how to solve the problem of light penetration to that bulk of material. Number one, this composite is highly translucent, that will influence the depth of curing for composite in order to ensure sufficient light polymerization of a thick restoration layer. But this elevated level of translucency will compromise your aesthetic appearance. How? Imagine with me that you have a glass plate. The very thin glass is absolutely translucent without any other effect that may impair the color of underlying structure. But when the thickness of glass increases, okay, it will add a grayish shadow. That's why bulk fill composite up till now is limited to the posterior, not anterior. It is not considered as a big problem when you are dealing with posterior teeth. Okay, it seems to be more grayish, but it is a great problem when you are dealing with anterior teeth. Okay, in addition to they adding also a light transferring initiator from ytterbium fluoride and spherical mixed oxides, which is called isofiller. Okay, in addition to your filler that will transfer your light for the other layers for a deeper layer, which is called isoceri. Okay, now your bulk fill composite will contain this shrinkage stress reliever, okay, which act as a spring, absorb some of the shrinkage stresses, okay, and reduce the effect of polymerization shrinkage at the interface, in addition to the glass filler, which has high modulus of elasticity like that of any regular filler particles of any composite. Okay, also you have an ivoserine initiator that will transmit the light, okay, to the remaining additional composite layers more than that or exceed that of 2 millimeters, maximum to 4 millimeters, in expense of your composite is highly translucent. But we mentioned that this is negatively affecting the final aesthetic quality, and as you see, okay, it seems to be in the right picture, it seems to be adding some grayish color or some grayish effect in your final composite restoration. Those are two types of commercially available composite, bulk filled composite. One of them, as you see, is cavity fills activated by ultrasonic activator. Okay, this ultrasonic activator also adds some sort of activation in addition to light to ensure that you already polymerized or your composite, and at the same time allowing sufficient flow of your bulk, okay, to wet all the cavity walls and reduce the effect of polymerization shrinkage. Then comes resin filtration, okay, with composite resin with minimal or no filler. The principle of it, okay, is just to penetrate and impregnate inside any defect of enamel, okay, to seal your enamel porosity, okay, that may attract or may be due to demineralization by acids from karyogenic microorganisms. Also, in some cases, okay, like white spot lesions which are not responding to bleaching, we play with this system. This system composed of a composite without filler or with minimal filler, okay, that could penetrate inside the porous enamel and seal the pores, okay, with a strong etchant that allow to open the pores much more to allow penetration of your resin inside it. Okay, in such a condition, they used 15% hydrochloric acid for gel for 2 minutes, while we used 37% phosphoric acid gel, okay, in case of regular composite as an acid etchant. The difference is hydrochloric acid already could penetrate and create pores for a depth of 58 up to 60 micron, while acid etching maximally penetrating up to 25 microns. Then washing your acid gel. But after washing, your air blowing could not perfectly remove all the water content from this depth of pores. That's why we used 99% ethanol as alcohol, okay, which evaporized, okay, and evaporize any water content. It's a good dryer for your cavity, okay, for this pores. Then applying a low viscosity resin, okay, of dry ethylene glycol dimethacrylate with no filler. The system firstly developed in Germany and known as Icon. This Icon, as you see, you have 3 tubes. One of them is the hydrochloric acid etchant, 15% for 2 minutes, okay, and you could repeat it several times until you get a fully chalky white satisfactory etching. Then your dryer gel, which is 99% ethanol. Then comes your resin, which penetrates into the open pores. Okay, for interproximal area, you have a special applicator, which is a nylon sac, okay, which is porous from one side to ensure that your acid etching gel just facing one side interproximally and protecting the other pores. There is a great difference between resin infiltration or resin filtration, okay, and fissure sealant. Fissure sealant is just protecting mechanically as a mechanical barrier, protective any defective fissure, okay, from recurrent caries, while our resin infiltration is complete impregnation of the material inside the porous or demineralized enamel. That's why it is indicated for outer enamel demineralization and sometimes in only the outer third of dentine, okay, that is diagnosed radiographically as CYSTA 1.0 and 2.0 and non-carious white spot lesions. Okay, this is the difference between fissure sealant and resin infiltration. As you could notice, resin infiltration, it's already infiltrating the lesion, okay, and stop that, while the fissure sealant in the occlusal, it's just a mechanical barrier. Let us watch with each other this movie of initial white spot lesions of 24 years old patient, okay, which is not responding to bleaching with a satisfactory result, okay, but it should be bleached. First of all, isolate the teeth with rubber dam, okay, then repolish the teeth to remove any stains, okay, then apply the first etch, which is 15% hydrochloric acid for 2 minutes, but it is not a passive application, it should be an active application. You should rub the etching gel, okay, at least 20 to 30 seconds, okay, and let the etching to work on a tooth at least for 2 minutes. Complete washing, applying of dryer, which is 99% ether that will evaporate, okay, and evaporate water with that for 30 seconds. Then visual inspection if it is sufficient etching or not according to the chalky white appearance of your surface. Re-etch, re-rub the gel, 30 seconds maximum for each tooth, and total amount of etching is 2 minutes. Reapply your Icon dry, let it to dry self-dryness for 30 minutes. Recheck again if you have sufficient etching. In such a case, they need to re-etch for the third time to ensure patent pores in which your resin could infiltrate. Now, good masking effect. One of the tips that you should separate between teeth in order to avoid your resin to infiltrate interproximal and occupy the interproximal space. Apply the resin. Actively and let it act for 3 minutes. Give it enough time to penetrate. Just air blowing to remove any excess, light curing for 40 seconds. Second, infiltration. It's important to separate between teeth while you are infiltrating with resin. Blowing the excess material. Recure again with light curing for 40 seconds. Polish with a special polisher, composite polisher, white stone. Polishing. And this is the final result with highly glazed translucent anterior teeth with no white spot lesion. Okay, this is another case of interproximal initial caries. First of all, separate the teeth using O-tie of orthodontic treatment. Let it for a few minutes until it separates the teeth a little bit. Isolate the teeth. Wedging to stabilize your band. Okay, at the same time to keep the distance between teeth patent. This is a special applicator, which is a piece of or a sack of nylon which is porous from one side. You should adjust the side porous to the tooth to be treated. Okay, and this prevents and separate the other tooth. This prevents any accidental etching of the neighboring tooth. Okay, washing. Also, the acid etchant is applied for 2 minutes, the same as the previous case. Okay, the only difference is this is a proximal lesion. Okay, classified as 1.0 from SISTA classification. Okay, this is the only difference. It's a proximal lesion, that's why you note here this is the dryer. The same steps as the previous case, but the difference, as I mentioned to you, in the interproximal applicator. Air blowing. Again, the same applicator with the porous side towards the tooth, but this time it is attached to the tube of the resin. And the previous or the non-porous side is towards the adjacent teeth to protect the neighboring teeth from accidental etching or accidental resin infiltration. Allowing it for 3 times, removing any excess material. Make sure that the material didn't escape to the interdental space, like curing for 40 seconds also. Re-infiltrate. Air blown to remove the excess. Check with dental floss that the contact is patent and we didn't glue the neighboring teeth with each other. And final cure. Then comes the smart chromatic technology or omnichrome. What is omnichroma? Okay, and what is smart chromatic technology? What's it? When you are restoring a teeth, you have a possibility of multi shades. Okay, at least 16 shades. Okay, ranged from A1 to D4. Ranged from, okay, reddish brown, okay, to reddish gray, and in between them reddish yellow, grayish shades, okay, and blah blah blah, okay, multiple shades. That means that you must keep a large inventory of different composites, okay, to accommodate a variety of shades. These are the possibility of shades you may face, and you may combine more than one shade. Okay? What if you get one shade that is compatible with all teeth shades, and instead of using these 16 shades? Okay? Depending on what's called structural color theory. What is structural color theory? Your color of any material could be amplified or weakened by the structure of any material on it that may have different wavelengths. What's meant by what I say? Let us examine this photograph. Okay, this is a feather of peacock. Okay, a drop of water, as you see, act as a magnifier that clarify the beauty of the brown color underneath. Okay, if you drop another water drop at this feather, what could you notice? I could notice something else. Either the color going to be faint, or it may be amplified much more, maybe more bright. What about if it is another material? What's meant by another material? Let us say it's a drop of oil. Then, according to the structure of the material applied on this feather, you may weaken or magnify the structural color of the material, okay, as it is transmitted through this one. Okay, what about if you drop another drop of water and could be adjusted to be of the same size exactly and the same sphere exactly, and another drop and another drop and another drop? Then you are magnifying the structural color of this peacock's feather, okay, and it will be transmitted to you as one color because all the drops are of the same size. Okay, let us apply this structural color mechanism to produce a smart chromatic technology. What is the smart chromatic technology? The manufacturer made a precise shape and the size of the filler, okay, within the composite material. Then it will transmit exactly and amplify the color of underlying dentine, and you will not in need to add any color modifiers to match this color because you already transmit the color of underlying dentine, okay, whatever the color of dentine shade recorded at which number. They get identical spherical fillers of perfect size and shape, adjusted to be of 260 nanometer diameter, okay, and they could generate red to blue light spectrum or color spectrum to match any tooth, regardless which color is it. Okay? This is the ultra structure of 260 nanometer identical spherical particles of omnichrome. And this is the other filler shapes of any composite you could imagine. Okay? This is schematic illustration. In normal conditions, the tooth is A1 and you will get composite A1. Composite A1 means that, okay, the game is played by your resin, not by your filler, because your resin already have a color modifiers which equivalent to A1, which reflects only the light in a wavelength of A1, and that's why it is considered as excellent color match. Okay, then if you insert a composite of A1, okay, into a tooth with shade record A4, again the game is played by the color modifiers of the resin, okay, not your filler. The filler have no role in this condition. Okay, it will also reflect the color of A1 while the tooth is A4, and this is considered as a poor color match. While if you used a perfect sized filler, the game now differs. The game now is played by your filler, not by your resin. Okay? Your resin is neutral. Your filler is of the same precise size. They will reflect exactly the color of underlying dentine. Regardless it is A1, okay, then A1 will be the dominant color and the others, okay, is undominant one or recessive ones that could not be observed. The same composite is inserted into A4 dentine shape. Your precise filler shape and size all are the same, will reflect the color of underlying dentine as a dominant one, and the recessive are the other light shades or guides. But in certain cases, such as anterior teeth with fractured incisal angle, or class 3, which is opened from the palatal up to the labial, having no reference of underlying dentine. This is a great problem. Let us discuss this one. Okay? You have beveled class 4. Okay? If you apply your chromatic composite without opaquer, okay, it will reflect the color of the tongue, the color of soft tissues, and it appears pink. Okay? And you are working inside anterior region, okay, and it will be a great problem in such a condition. How could you manage this? The manufacturers provide you with an opaquer of the same color of the tooth. Again, you used a regular composite in a form of opaquer, okay, just to block out the color of the underneath, okay, or the posterior tissues that will render your composite as a pink one. Then in such a case, you should have a blocker of the same color of the tooth, then apply the omnichromatic. It will reflect the color of the opaque. Okay, that's why up till now it is not documented to be used, okay, in anterior region, but it solves a great problem in posterior region. Okay, it's one color that fits all the shades of the tooth nowadays. Still up till now, it is limited in use, although it is recently added. I think it is recently added in 2019, okay, just 3 to 4 years ago. But still up till now, What about the effect of this precisely shaped particles? Okay, it is larger than that of nanofelt. Okay, composite. What about the effect of this on the physical and the mechanical behavior of the material? Still, there is deficient reviews about this, and still it is under investigation. Okay, this is the only chroma. Finally, these are the textbooks I used in this presentation. Your questions are welcomed at any time. You could contact me either by commenting to this video or by sending to me via email. I would like to thank you for assigning your precious time to listen to me. I hope you get any benefits from this lecture. Okay, please don't forget to subscribe to my channel and activate the notification to get all the news from this channel. Thank you. Yasser.